180,000. He was married 2 years ago and his wife was pregnant when he was diagnosed with this AML. So again the family had, and he is the only son. So family wanted to do anything extra, anything more, the best state of the art possible. And so very educated family, they searched and once again underwent a transplant on September 20th, and as you will see him to share his experience with us. And then it just started flowing, and over this 2.5-3 years we have done 20 transplants with 8 in lymphoma, multiple myeloma, acute myeloid leukemia, chronic myeloid and acute lymphoid leukemia. And these are our results. And what I have done is, these are our results. Say lymphoma, 75% survival rate at this time. Internationally, the expected results is 30% after 5 years for the kind of diseases which we have done, the transplant. At least 3 of these were primary refractory lymphomas for which you get only 10% survival even internationally at 5 years. So to put this in perspective, I have added these 2 columns, that the international results are 30% after 5 years, and with conventional treatment, if you did not do transplant, this would be less than 10%. And mind you that in oncology, when we say less than 10%, it generally means 0. But since nature sometimes gives surprises, mostly the quote in the statistics would be less than 10%. It generally means 0. In multiple myeloma, it is part of the initial therapy. So most of the time here, the expected results are for the long term. In the short term, you get about 20% at 3 years with conventional treatment and 10% or less than 10% at 10 years. So far it is 100% for us, and in the international expectation is 90% by 3 years and 50% at 10 years. This is a disease where on an average you would not see patients alive beyond 5 years. Most people, hematologists, oncologists, you ask them, they would have a rare patient who is alive after 5 years diagnosed with multiple myeloma. With transplant you get 50% survival at 10 years. So this is very good. In acute myeloid leukemia, more difficult disease, we have a 33% so far, and this is expected internationally, and without transplant this would be a very small number. In CML we have 100% survival. So far it is about 1.5 years for this patient who presented with very advanced disease. And once again, for this kind of disease, there would be no survival with traditional treatment. In ALL, our patient was discharged, survived 6 months, but he had some late complication, something called hemorrhagic cystitis of the transplant related, and could not survive. So overall, we have 75% patients in complete remission and doing well. So I really wanted to emphasize that these columns are very important, because traditionally people expect 100% from any new treatment, but that is never possible, and in a disease like cancer the numbers are even lower. So you must put this in perspective with these numbers. There will be mortality, there will be morbidity. We are not saying we will be better than international statistics in just few years, but we want to emphasize this column also, that without transplant, these numbers, you see most of them are less than 10% or 20%. Compared to that, these numbers, what we have, are much better. And that is the way to counsel the patient or think about this as an option. We also don't give our patients 100%. That okay, we do this and 90% you will be cured. We give them these numbers, which are the international numbers, and still they end up choosing it because the alternative options are very dismal for these indications. At Apollo, we have done the first successful allogenic transplant in private sector of Gujarat. He is here, that patient. We have also done the first successful autologous transplant in acute myeloid leukemia in Gujarat. This indication has been growing, and now when we started it was just appearing in the our guidelines, but now it is part of the standard guideline. Transplant is not a surgery, because many patients think that it is a surgery, like any liver or kidney transplant. You will cut the patient, you will cut the donor. There is no surgery involved in this. It has three main functions: a form of supportive care when you give very high doses of immunosuppressive or other therapies to take care of the cancer. You need some support, which is in the form of stem cells. And it has few other immunological functions, and in genetic disorders like thalassemia, it replaces a missing gene. So that is very simple concept. And there are about 50 odd genetic disorders with single gene defect where transplant has very good result. The sources are bone marrow, peripheral blood and cord blood. And if it is your own cells, then it is autologous, and if it is sibling or any other source, it is called allogenic. We mobilize the stem cells from the bone marrow using medicines like growth factors, and in case of bone marrow, it is aspirated under GA, and in case of peripheral blood transplant, which has actually made this technique much more safe, much more convenient for the patient and donor both, is the peripheral blood collection, which looks something like this, just looking like dialysis or any type of apheresis. So very convenient for the donor, and for this very reason there are many volunteer donors in the Western world. In US alone there are over 10 million, 1 crore voluntary donors for stem cells. They have given their names, registered in a registry called NMDP, where you can search, and if they match, they will come and donate for anybody in the US. And they can also send stem cells here. The collection will happen there and they will send here to India. So it is that safe for the donor. This is very important for everybody to understand. Unlike kidney or liver transplant, the donor safety is very good here, and nothing is lost permanently from patient's body. So our donors are working like from next day. And then we process them with various chemicals and store them at very low temperatures. And at the time of infusion, it is given like a blood transfusion after various conditioning regimens. Now, as I said, that we don't want the message to go out that this is something very easy and very simple and you just go and get it done. It is an intensive treatment with significant morbidity and mortality. In some of the indications, the international initial mortality is in the range of 10 to 40%. Okay, so it is a difficult intensive treatment. Dr. Jay Kothari will elaborate on this. This is a very established model, the hospitalist care in US. We have had no autologous treatment related mortality and only one mortality, which was in allogenic. So the commonest indications are multiple myeloma, where it is part of the initial therapy in all the guidelines, all the books everywhere, that you don't wait till relapse. You do this as part of the initial therapy after 2 to 4 months of the initial treatment. In lymphomas, for relapsed lymphomas, it is once again a standard treatment, and there is no other curative option with any significant results. In acute myeloid leukemia, it is part of initial therapy as well as the relapsed leukemia. Myelodysplastic syndrome, another very difficult disease for us with no other curative treatment, where it has about a 30% cure rate, and various other leukemias including ALL and chronic myeloid leukemia. Thalassemia, of the non-cancer indications, thalassemia has one of the best results with 80% cure rate in India and 94% in Italy. So there is a lot of scope for transplant in this indication, and you all know that without transplant a thalassemia patient does not survive to adulthood, maybe 20-30 years max if there is a very motivated parents, and that too at very high expense with cost of 10 to 15 lakh if you do the best care with filters and iron chelation and all that. By the age of 30 you will spend a lot of money and a lot of emotional resource, which with a lower cost you can cure a thalassemia patient, and you already see what is the possibilities. The best age for this is 2 to 5 years when there are least problems of iron. There are several other single gene disorders as we have seen, we discussed earlier. Aplastic anemia has a 70% cure rate with transplant, and this again you know that many of these severe aplastic anemias do not survive more than 1 to 2 months and die of either infection or hemorrhage. So for these indications, severe aplastic anemia, there is a definition for that with less than 200 absolute neutrophil count. Now many people think that this is very expensive treatment, but that is not the case. The autologous, our average bill at Apollo has been in the range of 4 to 6 lakhs, and the few fortunates even less than 4 lakhs. And allogenic it is 8 to 10 lakhs. With the kind of morbidity possible in this, occasionally we do counsel our patients that in 10% cases it can go much higher than this, and not to take this, once again not to take it lightly. Now I want to emphasize these other transplant costs so you understand that there is so much scope. For the liver transplant with a cost of about 20-25 lakh, there are 500 plus per year done in India, and kidney transplant about 3000 plus, and we are doing only 300 plus in India for the blood disorders and cancers. So there are a lot of patients in India who can afford life-saving good treatments. So in summary, these are the well-established indications for transplant. With the confidence that we have now after 20 transplants in the system and the team, this is what we are going ahead with. Next major emphasis is on thalassemia. There are over 50,000 children in India with thalassemia, with 10,000 new per year diagnosed, and Gujarat being one of the highest in number. So there is huge scope for thalassemia transplant in our state and India in general. We will expand to other indications and newer techniques like T-cell depletion. We are building a new state-of-the-art 6-bed stem cell unit, which many of you are aware. And very important addition to the family of Apollo is stem site in our campus, which will provide us with very good quality umbilical cord blood stem cells. And once again, this is not anything experimental or new. You can realize how behind we are. Already in the world, over 15,000 umbilical cord blood stem cell transplants have been done for various hematological and oncological conditions. So this is nothing experimental. It's just that we need to really establish our centers much better. Some of the patients who are not with us today because they are the international patients, I want to just show you their pictures. Those which were available in a short time, what we could get from them by email. This was a patient from Nairobi, Mr. Bimjibai, who was recently sent us the pictures. He is working actively, civil engineer there, and he is building a big temple in Kenya. So he has all the energy now to work after the transplant. This is a patient from Iraq, Miss Nada Ahmed, who again woman had a very difficult disease and she underwent transplant. She is well. Her brother incidentally also was transplanted before him, and what we are talking about, how the patients feel good here, that they send other patients to us. Brother was transplanted here with a very difficult lymphoma, and the sister developed the same thing about the same time, and she tried other medicines, other regimens, and came here for transplant. And there is a third patient admitted right now who is known to these people for transplant. So what we have been able to give as a staff, as the consultants, nursing staff and everybody, is that the patients are very happy. Some more pictures. Okay. With the last slide, I would like to thank so many people. There is a long list which needs to be up here, but due to the constraint of space and time, I have not added them, and I hope I haven't missed any of the key people. But first of all, the patients and their family members, without whose trust in us and the system and their courage to continue with these treatments and not give up, we would not be able to go ahead. Our nurses, housekeeping staff, these people have been also very, very diligent, because these are very delicate patients, very sick. They need to be taken care of, and they can easily pass on infections. The housekeeping staff, they are the people who otherwise nobody recognizes what they are doing, but they have also done very good job by not transmitting infections, taking very good care of the infection control practices. With their little knowledge, also they have done very good job. And so many other staff, the managers, secretaries, medical officer, some of us are here. Dr. Ravish, Gauri, Upasana sister is here. The hospitalist team is a very key part of our team, because we create sometimes many sick patients by the things we do. The oncologist and hematologist, the kind of treatments, conditioning regimens, chemotherapies that we have to give to cure these difficult diseases. Many times the patients are fairly sick. Many of them need a lot of counseling, because they need to stay in hospital in one room for 4 weeks. Okay, on an average 3 to 4 weeks they are in one room. Just imagine how difficult it is for anybody, and that too when you are not well. So they need a lot of counseling, lot of support, and that our nurses and the hospitalist team has been consistently providing. A transplant coordinator has a very important role. Dr. Jay is going to elaborate on that. Saraswati Ben is here. Saraswati Ben here? Yeah. Right. So Saraswati Ben Amin, she has a very long experience of working with transplant in US, and she has come here after retirement to India in Gandhinagar, and is helping us a lot in developing these things and counseling and helping the patients. Blood bank is obviously very important part of this, and Dr. Gupta and his whole team has worked very hard for this. We have pressurized them a lot to give us blood products immediately in numbers. Many of patients are from out of town who don't have relatives to donate blood. At that point, they have done drives in the hospital. They themselves have sat on the machines to donate platelet and other blood products. Dr. Gupta himself has donated single donor platelets several times. Our nursing staff has donated. This is very important, that these people are all involved. I want you to recognize that this is not part of their job to give blood themselves, but they are doing this. Dr. Aruna Gautam from microbiology, infection control teams, Dr. Saxena, Dr. Bhattavlekar, all the other labs, Sandeep Bhai and his team, radiology, operations, we have had lot of heated interactions for various supports that we need urgently. You can understand that these patients are very sick, we are very concerned, and we bother them a lot, and they have supported us with as much as they could do, and because of all that support we have been able to do these transplants with such good results. I am very thankful to all these people, the engineering team. So many people's support is involved in this. Many colleagues, infectious disease consultant Dr. Moti Talpada, and of course pushing them all behind is Dr. Pawar, and with all that push I think he's got sick today, so he could not make it here, but he has definitely pushed all these people so that everybody is behind this. This is a very large team effort. Thank you. Thank you all. I would now invite Dr. Jay Kothari, who is in charge of the ICU critical care and the hospitalist team, to explain to you this other part of the care which they do and how they help our patients. Thank you.
Good afternoon, everybody. I feel very proud to be part of the stem cell transplant program. In my life, when I was studying intensive care, I never realized I would reach here. A stem cell transplant and intensive care doesn't match. Most of my colleagues thought, they have queries, they have confusion. What is your role there in stem cell transplant, and why Chirag wants you to be there? It all started from one small patient when Chirag and we started working together, is that one of the patient has platelet count of 2000 and he wanted to put a central line for X reason. And he asked me, are you confident enough to put a central line in this platelet count? I said, fine, I've done that and we would be able to do it here. And that's how we started interacting. For the first patient, I put a central line, and from there, step by step, we started working more close for each patient. I started managing his patients when he was out of station, as he was the only oncologist. He didn't have the privilege to have other oncologists as locum, and I started managing the care in the ward. And from there, we evolved this concept, and the patients for transplant, he said that, can you help me building a team? I said, yes, that can be done. We would be able to give you support for 24/7 as and when required in the wards. So the concept started from there. He told me the concept about hospitalist in US practice, which was heard by us but not believed that in India we would be able to do practice in such manner. So what's the need for a team? We need to understand why it's the emphasis on transplant team. Most of the doctors traditionally think that this is my patient. I would treat this pneumonia, I would treat this stroke, I would treat this, and I would treat that. Everybody of us traditionally think this way. If we have to go a little away, then we have to think. By being in corporate hospital, in Apollo hospital, by being in tertiary care center, we have to think a little different. We have to think about the entire system, that how best we can manage 50 pneumonias, and what would be our mortality rate, what would be our average length of stay, how, if we are doing 10 transplants a year, how we can reach 100 transplants a year. A single person would never be able to do so. He has to create a team to reach 100 transplant a year target for his or for liver transplant or for any of such things. All of us has to work as a team, and this was the idea behind joining hands together inside. We have to think that how best we can improve our results in terms of length of stay, morbidity, mortality. We have to also think about enhancing the patient's hospital experience and the satisfaction. And being in team, reinstilling the confidence within the patient family, recounseling. When the difficulty happens, joining hands together, standing with the patient family, makes much more difference as far as satisfaction is concerned. They would come back to us, they would rely on us more strongly. And that was the need for Transplant Team, and this is what we've done in the cases that Chirag has mentioned. So what is the Transplant Team? Dr. Chirag Shah, he's a hemato-oncologist, and his team, Dr. Ravish. Myself, Dr. Maharshi, Dr. Manoj, and our registrars. We have Saraswati Ben as Transplant Coordinator. We have Ms. Gauri as Secretary, social worker, and Financial Coordinator. She does a lot of small things so swiftly that it didn't reach to us in our busy clinical practice. We have pharmacist team who helps us. We have dietitian who counsels, makes the dishes of Iraqi dishes and Mexican dishes and I don't know what. We have trained the nurses for transplant program. We have pharmacist who helps in administering chemotherapeutic agents. And of course, the hospital administration, which is supporting the idea and concept in the biggest possible manner. So what is the role of us hospitalists or critical care specialists? One is shadowing the other thing. We started working together from the beginning. A stem cell transplant or bone marrow transplant requires a very unique place where infection has to be under minimum possible rate. So from designing an infrastructure of the transplant unit, working with the hospital administration on those issues, we have certain protocols and policy development. We have to create compliance on those policies and protocols. We took a little extra